Good morning, everybody, and you are very welcome to this open disclosure webinar. If you're seeing me, it's not because you're at the wrong show today. My name is John Fitzsimons. I'm the Clinical Director for QI with NQPS, and I'll be co-facilitating today's open disclosure webinar on the Patient Safety Act 2023 and what it means for me with my co-facilitator, Juanita Gaidera. And we will be, I suppose, having a slightly different webinar today where it's going to be a little bit more conversational, and Juanita and I are here really to facilitate that conversation, and in particular to allow members of the open disclosure team to share their expertise in this area with a panel of people we've brought from across the health services today to start to open up, what the Patient Safety Act means for me. Next slide there, please. So we're going to be starting in a few minutes, but just to be aware, if you've attended these webinars before, you'll know that attendees are automatically muted, but you can engage with us through the chat box, and we would certainly encourage that. And I think later on, we'd like to have some interaction with the panel. We've a very experienced and wide-ranging panel, so we'd like people to be able to answer or to ask questions, and the panel will do their best to answer that. We won't be covering every part of the Patient Safety Act today. I think we're going to be maybe focused on more general elements of it, and then as time goes on, there will be further webinars that will explore some of the detailed and particular areas such as surgery, obstetrics, neonatology, screening. Those will be covered at a later date. So the session is being recorded, so you can watch it afterwards, or you can let your colleagues know about it. This is the second webinar, and I would encourage people to look at the first webinar as well, which was recorded back in February. If you have difficulty with sound, there is a telephone dial-in there as well, and some access codes that will allow you to access that. Next slide. So CPD is pending for those from the medical end of things. Hopefully that will be through shortly, and it is already approved by an NIMBY for CPD or professional development points there, and you can gain those points by just emailing the Open Disclosure Office. As you can see there as well, we will be joined by, I think, John and Michael today, two Irish Sign Language interpreters who will be available throughout the presentations and the conversations today.
Thank you. I'll disconnect.
And they will be changing over intermittently. You can also find closed captions if you look at the three little dots in the bottom right-hand corner of your screen. There are closed captions there that may also facilitate your reading what's going on in the session. So I welcome John and Michael to the session. Thank you. So we have a big panel today, and in order to do this, we're going to break this up into a number of different conversations. So we're going to have our first conversation will be between Bernie O'Reilly from Patient Safety. Bernie's the current lead, with Lorraine Schwamberg, who is Assistant National Director in QPS for Incident Management. And we'd like to welcome Mr. Tony Canavan, REO from Sailta Hospital Group. Then we're going to go into a second conversation around community and acute perspectives, including funded service, and we have Helen Thompson there, Ms. Paula Cusson-Murphy, and they will be joined by Angela Teisel, who people will be familiar from the Open Disclosure team. And then Angela is going to have a third conversation with Jeanette Cummins, looking at some of the issues for mental health services with regard to the Act. And then we're going to have a conversation with Dr. Jack McCarthy and Lorraine. Jack is in NCHD, and Lorraine Schwamberg, and I'll join in that conversation from the medical point of view as well, the role of the NCHD and doctors in general. And then finally, Angela and Lorraine are going to talk about some of the supporting implementation issues regarding the Act. And then we'll bring it together and hopefully have some time for questions at the end. When we were putting this session together, I think we recognized there were some needs, and we captured those in what we called, initially we called them the 3 C's, that we wanted today to bring some clarity, because this is new. It is confusing, especially if the law is not, what you're particularly familiar with. I think being clear on what my role within this, which is a piece of legislation, is going to be. So we want to bring clarity. We also wanted to bring calmness, and I think there's often some fear that goes along with this, and something new, involving the law in our work, I think for many people can be unnerving. So I think we want to reassure people that most of the things within the Act are things that we're already doing, and that there are some provisions and there are some sanctions as well that we need to be aware of. But I think it's important to know that this will be supported, and I think we'll all learn together. And that's our final, at least our initial final 3 was collaborative, that we need to do this together. I think no one group can implement what the Act is looking to do. So I think we all need to work together. One of our panelists then, Helen Thompson, suggested that there was a 4th C, and I would very much welcome this, and that's around compassion. And I think we need to remind ourselves that the Act is there for a good reason. It's there to recognize that harmful events and incidents happen within healthcare. That is not something that people intend, at least the vast majority of the time, and that the Act is there to help us recognize when harm happens, to address it, to learn from it, to disclose the events that have happened, and for us all to, I suppose, to learn and make a better and safer health service from this. So I think that needs to be done compassionately. We need to involve people. So I think we very much agree with the addition of compassion as our 4th C. So today we hope to be compassionate, to provide you some clarity, to calm any fears and worries that people have, and to remind ourselves that this will only happen through collaboration. So with that, I'm going to introduce our first conversation panel, and I'd like to invite maybe Lorraine to start things off with a reminder of just contextualizing a little bit where we are today, and telling us about the important features of the Patient Safety Act 2023. Lorraine.
Thank you, John, and thank you to you and Juanita for facilitating this vast panel of colleagues today, and Bernie, our patient partner. So just a quick synopsis. As you said, we had a webinar before where we went into the Act in a lot more detail as to the kind of intricate details of it, and we will be hosting another webinar focusing in particular on the notifiable incidents. So this piece of legislation, we have our open disclosure policy within the HSE that applies to patient safety incidents, but this particular piece of legislation, the overarching principle is that it's obviously supporting a culture of openness and transparency. Within it, there's a list of 13 specific notifiable incidents. And the specific list, whenever one of those notifiable incidents occurs as they are described in the Act, then we need to notify our regulators, so either HICWA, the Mental Health Commission, or the Chief Inspector. And we need to make that notification, hence the coined notifiable incidents, via the National Incident Management System. Now, the Act also provides some specific requirements as to the process around open disclosure, and it outlines, what's required in preparation for the open disclosure meeting, such as the role of the designated persons. They are written into the legislation. It includes some of the specifics as to what should be covered at any of the open disclosure meetings, and introduce the requirement to follow those meetings up in writing within 5 days. So while within our open disclosure policy, we obviously share the same sentiment in terms of keeping written records and capturing those in the healthcare record. This adds some specific details as per the example that you need to follow it up in writing. Similarly, specific to this is we need to notify our regulators within 7 days of becoming aware that the notifiable incident has occurred. It also introduces the mandatory open disclosure for patient-requested cancer screening reviews. So our colleagues in screening services have done quite a bit of work in terms of developing processes where a patient who might have gets a cancer diagnosis, where the patient can then request a kind of review of their screening history. So this act really cements the kind of supportive of the good communication around that. And additionally, it expands the role of HICWA and the Chief Inspector to an extent. The Act applies to private and public healthcare setting. So again, it widens the scope in terms of the open disclosure remit. And importantly, it provides some legal protections as to what's covered at the open disclosure meetings, contents, apology, and that, and around clinical audit. So again, that's meant to encourage our colleagues to engage with the open disclosure process. Now, we know it was enacted in May last year, and we are just waiting to hear confirmation as to when the Act will actually commence. So commencement means that it kind of kickstarts, it becomes into law, and we need to apply the legislation. Next slide, please. So throughout the webinar, because in particular today we are focusing on colleagues out in the system and patients in terms of what the Act means for them, we'll be focusing in on some of the key roles within the legislation. So throughout the Act, it refers to the health services provider consistently and the requirements of health services providers. So importantly, as I mentioned, it applies to public and private health service providers. So that is a person providing a health service or the corporate entity of providing a health service. That refers to particular, maybe private healthcare practitioners or partnerships, partnership of healthcare practitioners. And throughout, the responsibilities for the health service provider are really scattered throughout the legislation in terms of they need to make sure that the open disclosure meeting happens, that we report it to the regulator and so forth. So again, a lot of kind of onus, I suppose, within the HSE will be in line with roles and responsibilities of senior accountable officers and that to make sure that we have the processes and means of actioning these pieces. The principal healthcare practitioner, again, is going to be the key kind of, generally it would be the consultant, the kind of key clinician looking after the patient. And they are written into the legislation in particular as the main persons who would be undertaking the open disclosure conversation meeting with regards to the notifiable incidents. Now, it can, in some instances, be determined by the health service provider that maybe another person might be more suitable, or the principal healthcare practitioner might not be available at the time when you want to undertake open disclosure. The relevant person in particular, that relates to the patient or the service provider. Now, I have to forewarn you, the list of the notifiable incidents, while we don't go into them in a great detail today, the outcome is serious for all of them. For nearly most of the incidents, the patients will have died. So a lot of the interaction communication will be with the patient's relevant person. So that's either somebody they nominated previously or it is a spouse, a relative of the patient. And again, that's written into the legislation as to who that might be. The designated person, again, it's a really key role for the open disclosure process. So that is somebody who is assigned by the health service provider. So it would be an employee of the health service provider. And they are there to be the support person for the patient or the relevant person. and they are really a key role. Now, that designation needs to be documented. The health service provider needs to become quite clear who that person is in each one of the scenarios and incidences, and any kind of follow-up communication in terms of the meetings or anything like that will be through that person. Obviously, our regulators have a key role with regards to the legislation. So they're the persons, the organizations that we notify the incidents to. Additionally, it increases the powers for HICRA and the chief inspector in terms of some of the inspections that they might undertake and standards that they may set. Cancer screening services, so the Act is very specific in terms of the cancer screening services that relates to bowel screening, breast check, and cervical screening. The Minister of Health has a number of roles, I suppose, within the legislation, so he can add to that list of notifiable incidents. He's also put into the legislation that once it kind of kickstarts, once it commences, that it will be reviewed 2 years down the tracks. And he also can regulate for some of the, I suppose, bureaucratic requirements of the legislation that puts forward some of the kind of templates or statements that we need to prepare and that we would be communicating with following the meetings and that. Next slide. So I won't go into this in a lot of detail, but you will get a copy of the slides, of course. But this just sets out how the legislation is described, and we went into this in a lot more detail at the last time. So it's broken down into 9 different parts, and you'll see each part what they cover and what they're specific about. The next slide, please. And there you see, and on the bottom right, you will see some miscellaneous items that are covered. And within part 9 in particular is where you would find the list of those 13 notifiable incidents under Schedule 1. Next slide. I suppose for the HSE, we do have an implementation working group. We've been working on this for some time, I suppose. We're looking at a number of different areas. In particular, we have a few different work streams that are focusing on open disclosure piece, incident management piece, and the patient requested reviews in terms of screening, clinical audit. And then we also have a kind of a comms group where we're planning a lot of our engagements, these webinars and various other pieces. So some of the key actions that we're working on at the moment for our colleagues and for the wider system across the group and with our patient partners is to develop guidelines, guidance material, resources, training material, some of our templates. We're making those technical changes to the NIMS system with our colleagues from the state claims and a wider project group. But a particular focus for us is really to obviously implement the legislation and follow the 4 C's as you highlighted, John, and maintain a focus on staff support as well.
Thanks, Lorraine, and that's a great overview of where we are, starting from today. And I think many of those terms we'll come back to use, and we'll explore them in a little more detail as we go on today. And I think that'll be start to make things a little bit more clear to people as we go on. I'd like to invite Bernie into the conversation at this stage. Bernie, it's nice to see you. Good morning, and thanks for joining us today. Bernie, you've worked with Patients for Patient Safety now for a long time, and you and your family have had your own experience of disclosure following an incident. Do you think the Patient Safety Act is going to make an important difference in Irish healthcare?
I'd mainly like to think that the HSE policy would have covered out on any of the things that I felt shortcomings in the case of my family. But I suppose legislation, it does, when something becomes law, I think the biggest thing is that it's extended to the whole of healthcare. It's not just within the HSE. So everybody else has to catch up with what the HSE have already been working on over a long number of years. So I think from that point of view, it will make a big difference.
Yeah. And as you reminded us there, open disclosure has been with us for some time, and the open disclosure policies, and so certainly within the HSE. So this is perhaps building on that by putting it into a legislative form rather than bringing something totally new.
Absolutely. I mean, for our family, I think one of the biggest breakthroughs would have been having a designated person, because we definitely felt abandoned and lost in a system that we didn't know how to navigate. So for us, it was like, you know, when I felt resistance from the hospital that my husband died in, I thought, where do you go from here? Like, how do you get your answers? And I held on for the inquest, but like the inquest was a bit of a frustrating, tough day out. I didn't get my answers in the inquest. And in fact, I was somewhat taken back by the content of the inquest, in that our worries weren't aired, and really the inquest was quite led by the conjecture of the operating surgeon, whereas there were things that happened in Tony's operation, like, you know, Tony died of sepsis. He didn't have sepsis going into hospital. His sepsis was a direct result of a bowel operation. Where did sepsis start? How did sepsis start in the process? What could have protected him from inevitably what happened to him, which was his death? And as I explored, I found out quite early that Tony's operation had been interrupted because the on-call, the surgeon doing Tony's elective surgery was also covering the on-call rota for a big catchment area of Dublin, and there was a clash. An on-call emergency arose when Tony's operation was well advanced, and the surgeon left him to go and deal with the other person. So I always questioned that interruption. Did that interruption contribute to Tony's sepsis? Like the septic process progressed rapidly. Tony was dead within 3 days of the operation. So I had a huge amount of questions. And I just thought the whole process, I just was very disheartened at the time. And I absolutely lost my trust in healthcare. I thought, how am I ever going to trust healthcare again? And it was, I mean, I was years getting bits of information after I didn't know what I was entitled to at the beginning, because I didn't have that designated person. And I think that link person is going to be so important for people. If I'd had a link person from day one, a designated person, they would have talked me through. And sometimes the things we perceive as being, you know, rather shocking, like if someone explains it to us, you know, maybe that's processed within a hospital environment. We don't know these things. So designated person would have been really important to that process for me. And it would have, I mean, for me to continue, I'd say I was 9 years going through the system, looking for bits and pieces of information. Eventually, when I was no longer I became a litigation risk. I spent 3 years exploring you know, how I would get answers from my family. And it was only when I gave up that process and I wrote to Mary Harney, sort of in desperation, like, how can I ever trust Irish healthcare again, that she actually got me an external review. I knew nothing about reviews. And at the end of that process, it was 2 years, 2 years from the instigation of that reporting process, that I got my report. And in the report, I read that there had been an internal inquiry into Tony's death within a year of his death that I knew nothing about, hadn't been involved in. So that was very disheartening for me. And that just, it actually, I suppose, confirmed my feeling of being abandoned by the system at the time. You know, to read that 9 years later, I thought, well, I sensed that from early on, that there wasn't an openness. So much of the opening and the open disclosure process for me would be covered within the HSE policy. And that does give me huge satisfaction. I think the legislation, you know, I think people are going to worry about the legislation, and like, it's with us now, so we have to engage with it. So really, it's back to the honesty, integrity of individuals. Most people have honesty, integrity. The things that stop people from engaging, it's their own fear of process, or fear for themselves, disappointment in themselves if they've made a mistake. They didn't set out to make that mistake. If someone's been harmed, that is a huge wound on the person, a huge assault on their own life and their own career. So everybody has to be supported, like the families of people who are deceased, people, and not just them, like people who have, like, I always think that when someone dies, you know, the dead person doesn't experience the aftermath of that. You know, it's their families experience that. If somebody is critically wounded or injured, you know, has life-changing injuries as a result of a mistake, they experience that themselves. So those things also have to be taken into account. Like most of the incidents covered by the Patient Safety Act are of deceased people, but like there's worse things than death. So the people who have other life-altering injuries, they also have to be supported. And I'm hoping that the HSE policy will cover everything, but so does the rest of Irish healthcare. So I don't want people to totally, you know, just apply the law because it's there now. I want people to actually engage with the processes of human honesty and respect people.
Thanks, Bernie. And I think that's a real reminder of the compassion that's needed here, compassion to do the right thing for when, you know, patients have experienced an adverse event or a significant incident, and then you know, the right thing for healthcare workers and people working within the system to try and improve it and learn from that. Thanks, Bernie. I'd like to welcome Tony Canavan. Tony, good morning. You heard Bernie speak there. You're starting now in your role as REO in Ceuta, and why is the Patient Safety Act going to be important in Ceuta and, of course, across the country?
Well, and sorry, no, I shouldn't start off by correcting you, but as REO, I'll also be responsible for all the community services as well.
Yes.
Across that region. So look, I think Bernie has touched on it. You know, our practice has changed, and I've seen that evolve probably over the last 20 years. Certainly since I started working in the hospitals in 2002, I've seen quite a significant change in our approach to open disclosure. And some of that is just practice driven. Some of it is driven by professional development as well within medicine, within nursing, within allied health professionals as well. And some, as Bernie pointed out, of course, is also policy driven within the HSE. And so I have seen quite a significant evolution, I think, in our practice over the last 20 years or thereabouts. And I guess where this legislation comes in then is in some ways affirming or reaffirming that practice. But it's also, I suppose what it does is it kind of, it underlines our relationship as it should be between service providers and patients, or people who are experiencing or using our services in some ways. We talk now under Sláinte Care about, you know, partnering with patients and much more. And open disclosure is absolutely, it's about partnership. It's, as Bernie described it there, it's about us realising that the patient himself and his family are also part of the equation, as well as all of the professionals that are providing the care. So I think what the legislation does is it underlines that relationship, it underpins that relationship, and it moves it on to another level, which I think is really important. I also think actually the legislation will be a help for our staff. You know, as much and all as policy has been very supportive, and you know, you referred yourself, John, to the need for a compassionate approach to everybody that's involved in this, including staff, but also, of course, including patients and their families as well. But I still feel that at times staff aren't quite sure what to do. You know, they feel, you know, that, you know, what am I supposed to do for my patient? What am I supposed to do for his family? What am I supposed to do for the organization, my employer, and so on? What's the right thing to do? And, you know, when people are under pressure after a really significant event, you know, it's very difficult at times for them. So I think what the legislation does is it gives a little bit more certainty at that time. And I think that helps too.
Yeah, super. Thank you. And Tony, how do you see this working then in the region? What are the key actions, you know, as the act comes to commence now in the near future?
Well, there's all the practical things, you know. So for example, we have to first of all, we have to comply with the legislation, but also we have to be able to provide assurance that within the services we're complying with legislation. And that inevitably will mean some sort of a monthly or quarterly report or a template that needs to be completed and submitted and considered and followed up actions taken from that. So there's all the practical arrangements around that, and they're not to be. I wouldn't kind of understate those. They have to be done well. They have to be done on a consistent basis across all of our services, and you know, this covers a very wide range of services from mental health through to hospital services and so on. So it's not an insignificant task. but it's only the first step in it. And you know, I'd like to see, and I think from a service provider point of view, our ambition needs to go beyond just compliance with the legislation. It also has to, you know, use the legislation as a further lever to develop that relationship that I referred to earlier on. So I think there's the real onus on managers like myself to ensure that we go beyond simple compliance and try and get what we can for our services and for patients out of this new legislation.
That's great, Tony. Thank you very much. And I hope maybe you can stay with us for a little bit if you can. And Bernie, you're going to stay with us as well. And we might have some discussion from the panel. I'd like to thank everybody here at this conversation. And I am going to hand over to Juanita now, who is going to talk to Helen and Paula about application in the acute and the community sectors.
That's brilliant. Thank you very much for that, John. And just to introduce Helen Thompson and Paula Cusson-Murphy, and obviously you'll know Angela, a lot of you already. So welcome to you both. You're both QPS leads in the community and the acutes sections. So what we might just start off with is just a little bit of, I suppose, a discussion about the impact of the legislation. And Helen, in your role, we might start with you as a QPS lead within the community services. What parts of the legislation do you feel will impact the community services the most?
Díomh go léir, many thanks for that question, Juanita. Within QPS and within QPS in the community, our role is very much to scaffold and support the services to meet their legislative requirements. So obviously, with having, you know, initial scoping of the legislation and looking, you know, what does that mean for us here in the community, has been cognizant of all aspects. The parts that will most impact on us here are, you know, the mandatory requirement to complete open disclosure and all the associated steps with that, and there are a few. Also the reporting to the regulator and that additional reporting requirement, because, you know, it will be secondary to the reporting requirements that are already there. And the other aspect, again, be cognizant that some of our services are delivered to, you know, commission services, Section 38, 39s, the requirement to inform the provider as well when there has been a notifiable incident in your service. So they're, you know, certainly the initial aspects that I think will impact on us here in the community, whilst being aware of the other ones as well, you know.
Okay. And you're right there, you're touching on something there about the fact that we're building on what's already there. You know, that there is a very strong reporting culture and structure in place at the moment, so it's building on that. And we might just, we'll come back to you in a second, but we might just go to Paula from an acute perspective. You know, in terms of the impact within the acute services, what are you thinking of from your perspective?
Yeah, thanks, Juanita. I think probably your point is well made there. I think we're building on what we already have in place, and I think we've known this has been coming for a while. So I think we've been developing our systems and our processes as we've been hearing as what's going to be contained within it. I suppose the piece for us is that it's about us having a look at our processes. Well, what are our processes? We now have, as Helen has said, this is now mandatory. So when we now have 12, I call them 12 plus 2, the two hypothermias, I call them 12 plus 2.
Yeah.
So they're now mandatory notifiable incidents. And it's that piece around, well, how are we going to manage that? How are we going to do that notification piece? So they're all pieces that we're looking at. We now know that we have to notify the regulator within 72 hours. So how is that going to happen? So we're asking the questions, well, our NIM system does a certain amount, but we now need to use the NIM system to notify the regulator within 72 hours.
Yes.
We're now legally required to appoint a designated person. So what are our steps? So what are our processes around, well, how are we going to do that? And we already, like as Lorraine already referred to earlier, these are serious incidents. We're already doing open disclosure, but it's just how do we fine-tune our processes so that we come in line with the legislation. So it's not that this is all new. We're already doing this because there's, as Lorraine said, unfortunately these are ultimately resulting in debt, and we have to complete. our open disclosure process, and we're doing that. So we have to just fine-tune our processes so that we structure our meetings in line with the legislation. So we're looking at, well, that's the impact. How do we structure it? So we now have a guidance from the legislation as regards how we're expected to do it, and I think that's just really, really helpful. And the other piece I think that we're looking at from an impact piece is our record keeping. How are we keeping, because we now are legally obliged to retain our records, and it's about, we're looking at, well, what are our processes around that, and I know we're looking at that nationally as well. So that there are some of the things that we're looking at, Juanita.
Yeah, and I think it's an important piece there. You know, you talk about things that we're looking at the moment. We are in the preparatory stages of this at the minute, before commencement of the actual legislation itself. Are there other operational challenges that you'd see in place, Paula? And you know, what's happening to address them at the minute? Because as you said, these are all things that we're teasing out, but how is that happening?
Yeah, I suppose the first piece is getting the information out into the system. And that's the beauty of these webinars, and all the, you know, the newsletters and things like that. It's getting that information down on the ground and getting down to the people who are actually providing the services. So it's really, really important that these are happening. The training for us, and I know the training is being looked at, because we're providing face-to-face training, but the face-to-face training we're providing needs to cover the legislation, and I know that's being looked at just to revise it, and that's really, really important. Our processes, I suppose we're legally required now to mandate, so we're legally required to appoint a designated person. So it's those processes and notifying the regulator. So we know that we're looking at our NIM system. We know that open disclosure is just a simple field at the moment, but we know we're looking at the different screens and how we're going to use then our NIM system to do that notification piece. And then records management. I know we're looking at nationally, the system is looking at, with the input of people around the country, how our templates, they will be really, really important to us. And I suppose just simplifying it and having consistency across the board. So I think those pieces, those processes. And then as regards, I suppose the piece that I think that we need to look at is, and that's at the end of it, when you look at it, is the learning from the processes. And I know that's something we're going to do more on with the input of everyone around the country, is how are we going to learn from these innocent, what formal process are we going to have to put in place so that we do learn from it. And I think the other pieces that we need to look at is, and that will come with the templates as well, is our minute taking, is how we're going to structure a minute taking so that we give people proper recollection or a proper feedback of the meeting, so that we have an accurate reflection of what has been discussed in the format that is under the legislation. I think they're all processes, but there are lots of working groups that are looking at all of these, and I think so. The piece I think for me is that this isn't us reinventing the wheel. This is us building on what's already there, and this is us working through the processes together so that we have consistency at the end.
Okay, that's I suppose really important to note that, and it's helpful to have that sort of clarification as well, that there are groups in different areas looking at it at the minute. I'm conscious as well, you know, from the community perspective, it's going to be a little bit different and a different dynamic. So Helen, from your perspective, what's coming up from an operational?
Yeah, again, a lot of similar operational challenges in the community, but I think also we have to highlight the fact that the structures, the breadth and depth, the geographical spread within the community does make it a little bit more challenging in terms of communication, socialization of the whole, the Act and the requirements. So we have a lot more challenges around that within a community setting, especially one as big as our CHO here. But obviously we will piggyback in on the existing structures that are there. We've already, you know, obviously discussed it within our CHO QPS structure, senior management team. It'll be socialized down to all those structures. I think a big challenge is just that whole education, bringing people on board and understanding the different roles and responsibilities. You know, the health practitioner aspect, the provider aspect, the designated person aspect, which is huge. So there'll be a lot of support required. And I mean, again, as I said at the beginning, that's our role within QPS, to support the services with that and to translate what the Act looks like back here in the community and locally. And, you know, from initial scoping, it certainly looks like, you know, there's 3 particular notifiables there that would stand out to us in the community, and you know, especially, you know, the medication related death, the one with regard to the medical intervention, and particularly the suspected suicide, and I know that will be spoken to later on in this webinar. The reporting requirements, that's a huge aspect, because there's a lot of competing demands in the community at the moment and across healthcare generally, with ADM legislation, additional regulatory requirements within mental health, etc. So, you know, there's a lot of competing demands. Resources will be challenged, and, you know, we just have to try and align as much as possible with our existing structures and build it in there. But it is going to take a lot of consideration, work and effort for everybody within the community.
Okay, I think that's helpful. I suppose one of the things that's coming up, and you touched on it, the relationship with Section 38 and 39 organisations, which is fundamental to provision of community services. How do you see this working in that space?
And again, you know, in relation to that aspect, it's looking at our existing structures that we have there and our existing assurances process through our integrated management review meetings, you know, our existing governance and management structures, and again, knitting it in there as much as possible. But it is early days. We're definitely on a journey, Juanita, and this is all to be stepped out, socialized, considered, and then communicated and agreed through those processes. So we need lots of discourse, lots of conversations, but, you know, I think our goal would definitely be to try and align as much as possible to what's there and integrate it into those processes.
And I'm conscious, you know, talking about alignment, we had Tony, we heard from Tony earlier on, you know, obviously this is all happening in the context of a significant change process within our organisation, and an alignment of services and integrated care, and that focus on bringing services together. I don't know, Paul or Helen, either of you might like to touch on that and how this is, you know, working in that space.
Yeah, thanks for that, Juanita. Again, when I mentioned the competing challenges at the moment, I suppose that's another one. We are in uncertain times at the moment. We've yet to see how everything will be structured going forward. But ultimately, from our perspective, the most important person is the relevant person, the service user, the patient, the resident, whatever word we want to use in terms of our service delivery, and making sure that ultimately all the changes that may be ahead for us will all align to ultimately ensure, you know, safe quality services, and where things do happen and things do go wrong, that we have our structures in place to ensure that open disclosure occurs and is supported. So it has to be at the centre of those changes going forward. That is our perspective on it anyway.
Okay, and I'm conscious you talked about the person at the centre, and we heard from Bernie earlier on, and she spoke about how helpful it would have been to have had a designated person in post, you know, at the time of her husband's death. And I might come back to you, Paula, because I know that, you know, you're very familiar with this in your role. How important is that role of the designated person within our current open disclosure policy and incident management framework following a serious incident? You know, who fulfills that at the moment, and do you think that's likely to change following commencement of the legislation?
It's I can understand Bernie's perspective on this, and I can empathise with what she's described. I suppose the designated person, for me, it's an absolutely critical role. They're the link between the people who are affected, who are really affected, and what we have done. I'll just take you through what we do. We've designated that our PALs, our patient advocacy liaison staff, are designated persons. So when we have a serious incident, such as what's in these notifiable incidents, at our CEMT, we make a formal referral, comes from the CEMT to the PALs team, requesting the appointment of a designated person, and they become the link person between the services and the people who are affected. We know it's a legal requirement now, and the pieces that we need to now get right are formalising that process across the system, so that we have a standard approach So we need to start thinking about, well, who are those designated people going to be? And it's not everyone. That's the piece I think that's really important, is not everyone can fulfill this role. There are skills, there are training, and there are competency, and it is not for everyone. There is a skill set that you need to, when you're recruiting people to this role, that they need to be able to meet, because they need to have, as John referred to, that compassion, but that empathy, and to be able to be that supportive person for the people who are affected is really, really critical. And the piece that we have to, that we now find with this legislation that we're looking at is how do we tie all the pieces together? Because at the moment, everyone keeps their own records. We now need to come to a central point where they're all kept together. And it's the clarifications. The clarifications happen now, but now we have a legal piece around them from this legislation. Families and their loved ones come back on a regular basis looking for clarifications, and the designated person, as we would see them, as our PALS manager, fulfill those roles on a daily basis. So it's going to be a critical role, and I would stress that it's really, really important to make sure that we get the right people into these roles, that they become the support that the families and loved ones need, and not somebody that we just want to fit into the role. Is going to be really, really important in the considerations of the designated role. And I welcome the fact that there is specific training and that there's a specific national group looking at this and are providing and are looking at, well, how are we going to train and to train the staff up to fulfill this role. It's really, really important.
Okay, thanks for that, Paula. And just on the topic of training, I might bring you in there, Angela. Just see a question in the chat from Fidelma, but it might be helpful just to share with the broader group in terms of that training for the designated person. Has that commenced, or what stage is that at the moment?
Yeah, maybe just to reinforce Paula's message around the importance of this training, because we know from our work to date in open disclosure, and you heard Bernie saying earlier, the importance that this person has on the experience and the outcomes for patients and their families when they have that person, that go-to person that can, help them prepare for meetings, that can bring their questions, clarifications back to the team, that they can help them prepare for meetings, that can accompany them to meetings. It really is such an important role, and we can't underestimate the amount that is involved in that role. So we have some training on our designated person in our e-learning module 2 at the moment, and it is included in our face-to-face training, but we are actually now developing an e-learning program on the role of designated person, and we have some patient liaison staff who are going to be involved in the development of that. And we hope to have that developed probably towards the end of Q2 of this year, so definitely rolling it out in Q3. We are also developing, and we have our lesson plan done out for this training, and just about to put the content together for the face-to-face skills program, again on the role of designated person. And again, I know, Paula, we're going to be testing it out down in the West with some of your patient liaison staff. So again, we hope to pilot that in Q2 of this year, get some feedback, and then with a view to rolling that out again in Q3, Q4 of this year. I just like maybe just to add a couple of things, just listening to the conversation, Juanita, if that's okay. Just maybe just things I agree with in relation to what Helen and Paul have been talking about. And I suppose for us, Paula and Helen are both open disclosure leads, which I think is really important. And just in relation to the setting up of the regional areas now, it's going to be really important that we keep those open disclosure leads, and that they're built into that structure in the new regions, and that under the National Open Disclosure Framework, we're also required now to identify clinical open disclosure leads in every area as well. So that going forward in that kind of governance structure, that not only will we have our non-clinical leads, but we'd have our clinical leads as well, working together in these new regions as part of the governance structure to actually support the role and implementation of the HSE open disclosure policy. So for us, that whole leadership role going forward is going to be really critical. And our leads really, the success of our programme has been down to the work that our leads and our staff have done at local level. We support that work, obviously, but it is you who make this happen on the ground. And so just some messages really that both Helen and Paula have said really is about not reinventing the wheel. There are structures, procedures, processes in place for the management of Category 1 instance and SREs to align these notifiable incidents with those structures. I think the roles and responsibilities pieces are going to be very important as well in relation to people knowing their role and responsibility. For example, who's going to be responsible for notifying the senior accountable officer that has one of these notifiable incidents has occurred, who's going to make that notification to the regulators. That all needs to be very clearly defined and clear at local level. And again, just for staff now to start identifying the staff in your service who are going to fulfill that role of designated person, and so we can get those people identified and have them ready then to come out and attend the training. So again, I think I saw a question in the chat as well about the notification to the regulator. I know particularly for yourself, Helen, in the community, that this notification will be done, and the Act is very specific that notification will be done via the NIMS system. Yeah. And the system is currently being adapted to do that, but also for our Section 39 organisations or any organisations outside even private services, there will be a portal as well into the Mental Health Commission and HICWA for making those notifications, and that is attached to the NIMS system as well. So just some maybe final comments for the section, Juanita.
Brilliant, brilliant. Thanks very much, Angela. And just before we finish off, you touched on there that piece about the notification. But if an event happens at the moment, and maybe I'll just go back to Paula and Helen quickly on this. If an event happens at the moment, who do you contact locally, and is that likely to change? And just maybe before we move on, so I'll start with you, Paula, if that's okay.
Yeah, Juanita, I suppose we have a QPulse system. That's what we use at the moment, and that's not going to change. It's our notifiable system. So once we have an incident, that there's an automatic email generated that goes to everyone in senior management to advise them of the incident.
Okay.
Now it's a bit of a double entry, so we then transfer that to the National Incident Management System. But there's an automatic process in place, and I don't see that changing. That should still be the point of initiation.
And is that the same in most services, or is it fair to say that some services will be different?
Some services will be different. Some do direct entry on Teams. Yeah.
Brilliant. Okay, that's great. And Helen, for yourself.
Yeah. Here within the community, we have GPS advisors who support each operational area, who would monitor the incidents and the NIMS constantly, continuously, and also through our governance and management structures in each of those operational areas as well, to be made aware. Because as you say, these are really significant incidents. They're all category 1s or SREs. So once that's communicated and the teams are aware immediately, even as is, the QPS advisors will be supporting the operational areas and the senior people in terms of meeting the requirements of the incident management framework. So that's already established, and that process is already there. Again, in terms of, supporting the completion of the preliminary assessment forms and the standing up of the SIMT and meeting all the requirements, as I say, as per the IMF with that. So again, going back to that whole idea of integrating with what's there, initially that's certainly where we'd see the open disclosure mandatory requirement kind of integrating in there, because we already have that structure there. But it will take a bit of work, it will take a little bit of time, but look at, we'll all be there collaborating, working together to get it right.
Get it right. That's brilliant. Just thank you both, Paula and Helen, for joining us, and thanks to our interpreters who are busy keeping things going at the moment for us, so thank you for that. And Angela, I know you're going to join us in the next section when we're joined by Jeanette Cummins, who's a principal social worker. And just to say that in the next section we'll be speaking about an example of suicide, which we know that some participants might find upsetting, and just to say that the section will take about 10 minutes, so if anybody does want to step out, you can come back in about 10 minutes time. We just wanted to share maybe an example of one of the incidents that might come up within services, and how or if that will change. And thank you to Chris for supporting us in the changes over, so that's great. So welcome, Jeanette. And just to say that the suicide, a notifiable incident, an unintended death where the cause is believed to be the suicide of a patient while being cared for in or at a place or premises in which the health service provider provides a health service, whether or not the death was anticipated or arose from or was wholly or partially attributable to the illness or underlying condition of the patient. That's the definition, you know, within the Act. That's the wording there. And we might just start off with yourself, Jeanette. What are the current notification requirements when a death by suicide is suspected? And you might just tell us, how is the notification made at the moment and who makes it? Just to give us some context for the types of changes that might come.
Okay, apologies in advance. I have a cold this morning.
It's okay.
So, but I suppose currently within mental health services, under the incident management framework, all category 1 incidents are rated as extreme or major harm, are classified as serious reportable events. So we're talking about, I suppose, deaths that occur in the community and in the approved centres. So if a staff member becomes aware that somebody has passed away, possibly as a result of suicide, the NIMS forms is completed immediately by the staff member. And that serious incident is immediately then notified to the local accountable officer. And within the community, that would be our executive clinical director. And within the approved centres, it would be the clinical director. So they're informed immediately, and the local accountable officer will then notify the senior accountable officer, and that is the head of service for mental health, within 24 hours of the incident occurring or of our notification that an incident has taken place in the community. So the incident form then for the category 1 must be sent directly to QSSI, and QSSI upload the NIMS and then return the number to the service. The service then completes the preliminary assessment, which informs the SIMT meeting. And then at the SIMT meeting, then the family liaison person would be identified at the SIMT to liaise with the family in the aftermath of an unexplained death or a suicide.
Okay.
So that's the first part of our reporting as it happens at the moment. And then the second part of our reporting procedure would be that we must report to the Mental Health Commission under the guidance on quality and safety notifications. And that is on the CIS system, the CIS system. And the death notification must be completed by the treating consultant for the person. So if a death occurs within the approved centres, that notification must take place to the Mental Health Commission within 48 hours. And if it's a service user who has been discharged, possibly in the last 4 weeks, or has been transferred to another facility, the Mental Health Commission must be notified within 7 days. And the third thing that we must also be cognizant of is that all known service users, in the event of sudden and unexplained death, notification must be sent to the Mental Health Commission within 7 days.
Okay. Okay, Jeanette, thanks very much for that, because it's quite technical and there's a lot of different elements of it. And I know that when something happens like that, there's obviously supports available to help people to navigate that process. You don't have to remember it all, that there's supports there. But we might just go to Angela, just in terms of the changes that are likely to come, you know, with the Act. Could you maybe just tell us, you know, how will the process differ to the current practice? And thank you, Jeanette, for that.
I think just to start off with, this notifiable incident relates only to the death by suicide that occurs while being cared for in or at a place where health service is being provided. So I think it's really important to differentiate that. And I think the thinking behind this notifiable incident was actually the current serious reportable event 3C. And that relates to all sudden unexplained deaths or injuries which results in serious disability of a person who is inpatient or resident in a mental health care facility. So I think where it relates to in or at a premises, it can be a hospital or it could be a designated centre where the patient is being cared for. So, so what is outside this notifiable incident is where a patient dies by suspected suicide in the community or any other external place outside of HSE building or premises. Now, premises could actually indicate the land that the I suppose that the building is on as well. What is also, we believe, just on clarification from the Department of Health, is where a patient is admitted to hospital following self-harm or attempted suicide and dies following admission, that also would not be included in this notifiable incident under the Patient Safety Act. So again, it's just some differences there. I think that the other thing is that while currently that the notifications to the Mental Health Commissioner made under the Mental Health Act, there is going to be an additional requirement now to make another notification under the provisions of the Patient Safety Act. And the reason why there can't be one notification to suit both is that they're two different pieces of legislation based that we are notifying under. So there will be that additional notification to be made via the NIM system or via the portal, as we mentioned earlier. And really that then when there is a death by suicide on or at a premises, that is dealt with, that the open disclosure is managed under the provisions of the Act, that designated person is signed legally under the Act and that is documented and kept on record, and that obviously all the documentation requirements around the Act are adhered to as well. So I think they are the main differences, Bonita, in the practice of managing the suicide will be the same. It's just the kind of the additional requirements that we need to consider in the context here.
So there'll be the double notification, and just in terms then of the access to the NIM system. So if we don't have access to the NIM system, is that through the portal that you've spoken about, or is there another approach?
Yes. Well, just to say that where people have access to the NIM system, it's really important that they use the NIM system, that they don't go into the Mental Health Commission website, for example, and use the portal. So the Act is very specific that this notification is done via NIMS, where NIMS is available. And then behind the scenes, we have our Mental Health Commission who are working hard with HICWA and with the Department of Health and State Claims Agency at the moment and HSE to develop, develop NIM system further to make these notifications, but also to develop this portal, which will be a web-based portal that they can actually make the notification via.
Okay, and just to check then, will there be follow-up from the regulator after there's been a notification?
Yes, and I suppose where the notification is made for notifiable incident, I know that Jeanette was talking about different timeframes. It's 7 days that notification for all these notifiable incidents must be made, and also the regulator then must come back within 21 days of the notification being made to acknowledge notification. They also have an entitlement to come back to seek additional information around the facts relating to the incident as well at any stage. And there are certain criteria that the notifications will be looking for as well to the regulator, and basically around the name of the service, the notifiable incident that's happened, when it happened, when it came to the attention of the service provider, and any actions being taken to address that incident or to mitigate against that incident, and also any actions taken to share learning as well. So they're the types of things that the regulator will be looking for, and they're set out in the Act. But in addition, the regulators have come back to us now, and they are going to be requiring information around open disclosure as well as part of that referral process. So you can see that the open disclosure is really standing out as being very important for the regulators as well.
Absolutely. And just there is a question coming in from Una at the moment. She's just wondering, where a patient absconds from an approved centre and dies by suspected suicide, is that considered a notifiable incident?
I would imagine it would be, because they're under the care of the service provider at that time. What I know is exempt is where maybe a patient is under or service is under approved leave from a designated centre and a suicide happens at that time. Maybe they're in their home, and that is not included as a notifiable incident. But I believe where they are under care and they abscond if something happens, that it would. But we'd probably have to follow up with that and get clarity on that, to be honest.
Perfect. That's helpful. Thanks very much for that, Angela. And I think Lorraine has just raised her hand there. Do you want to come in, Lorraine?
Sorry, I pressed the wrong button. No, I wanted to concur with Angela. So they'd be under our care. I wanted to give the thumbs up, but I raised my hand. Apologies.
That's absolutely perfect. That's perfect. And just to say, we're just coming to the end of the session, but to thank Jeanette and to thank Angela for sharing that example. And we're going to go over to John now and Jack McCarthy and Lorraine, just to look at this and the implications for NCHDs. But just to say thank you again to Jeanette and to Angela for sharing their information and their knowledge on that piece. Thank you.
Thanks, Juanita, and thank you to all the panelists there. I'd like to welcome Dr. Jack McCarthy. And Jack, thank you for giving up your time and engaging with us. You're a medical SHO in St. Vincent's Hospital. And Jack, obviously, you know, the Act, you know, requires that the disclosure of a notifiable incident is made by the principal healthcare provider or practitioner, which is generally going to be obviously the consultant, but consultants and NCHDs work very closely. And what do you think are going to be the features of the Act that are going to be important for NCHDs to know about? And what are the things maybe that NCHDs are talking about that are interesting them or concerning them about this?
Yeah, thanks very much for having me and letting me speak. As far as what I see as NCHD's role in the Act would be largely in relation to communication and support. So when I look at the notifiable incidents as an SHO, they're all extremely serious incidents and not ones that I think an NCHD should or will be dealing with by themselves. So firstly, I think our role would be communicating with the primary healthcare practitioner, so the patient's primary consultant or the relevant specialty consultant on call if the patient's consultant isn't available, as well as communicating with the QPS staff department in the hospital as quickly as possible. Secondly, as NCHDs, often we are the first responders when incidents happen and stuff goes wrong. And this could be in the middle of the night when there's not many other staff around. So the importance of documentation from our point of view, to have kind of accurate, clear and concise documentation if an incident does occur. And then I think communication to families, obviously, as you'd said, and as the Act states, the primary person responsible is the primary healthcare practitioner, the consultant. But if something does happen in the middle of the night and the consultant isn't immediately available, the most senior NCHD for the relevant specialty might need to step up and be able to communicate with the family, and just so that they are aware and are able to recognise these incidents and the HSE guidance and policies on open disclosure. But just to communicate, to echo what yourself and Bernie said, to communicate in a calm, a clear, and most importantly, a compassionate way if an incident does occur.
Thanks, Jack. And is this something that most NCHDs are aware of now? You know, that the Act, you know, being about to commence and what it means.
I think it's difficult for me to comment for all NCHDs. Some of the notifiable incidents are quite specific. Well, I'm primarily practicing medical specialties. Some of the notifiable incidents are quite specific to specialties such as psychiatry, obstetric surgery. Yeah. Personally, I haven't found much discussion or awareness of it, but it's good that there are supports available, as we've discussed today, with the e-learning, HSE land e-learning in relation to open disclosure as well. And I would hope in my role as the NCHE representative with the Open Disclosure Committee that I could raise further awareness of it before it comes into place, but that the relevant training bodies for each specialty could help raise awareness for their NCHDs so they're aware of what their responsibilities will be when the Act comes into place.
Great, thanks, Jack. Lorraine, I might just ask you about, you know, that open disclosure obviously has been in place for many years, you know, now through the HSE. What's going to change when the Act comes into play, you know, to open disclosure, and what's going to be different? And I think, you know, things that people need to be aware of.
Yes, I think it's been said a couple of times, just the specific notifiable incidents, the requirement to report it to the regulator, making sure that we have those processes in place. and the specific requirements around the kind of written record and the meeting and that. And we're definitely aligning our open disclosure policy to make sure that there isn't any variation where we can avoid it. Now, obviously, the specific requirements around the 7 days to report to the regulator, 5 days to follow up in writing, that's very specific to the legislation. But yeah, we're trying to make it as seamless as possible, and certainly the comms and engagement piece is a big area that we're looking at the moment. So hopefully we will be reaching our NCHD audience, and I know that the team are kind of doing a bit of a roadshow in April and May and visiting different hospital and community sites and that. And I think once we know the actual commencement date, that everything will be ramped up towards that. The regulators will be providing guidance to us as well and guidelines and that. So I think there will be a plethora of information coming with regards to this. I know colleagues mentioned around some of the challenges, maybe with the changes that we're undergoing in the healthcare system, but actually maybe the timing's just right. Like maybe with the changes that are coming, to have this kind of aligned with those changes and having it high on everybody's agenda. So planning can look at, the role of the designated person, of the clinical leads and all of that. So maybe we're just striking while the iron's hot. It might be a good opportunity.
Great. Well, thank you both. And again, I'm sure this is going to be an ongoing conversation, and I hope you can stay with us. I'm going to maybe go back to maybe all our panelists and invite Angela and Lorraine as well to join us. And I think we're getting tight on time, and I think I've been watching the chat, and I think a lot of questions have been responded to within the chat. Juanita, are there any questions there that we maybe haven't responded to yet?
Yeah, no, I think we're okay, but I think it might be helpful just there is a question about open disclosure, and we might just go to Angela for a second. Just, obviously open disclosure is well embedded within the HSE and funded services at the moment. Will that differ under the Act?
I think, as Lorraine was saying there, that the Act aligns very nicely with our current open disclosure policy. So, and I think what Bernie was saying earlier as well, is that, we mustn't see the Act replacing our policy. It's actually building another layer to our open disclosure policy, where it brings that mandatory open disclosure for that specific list of notifiable incidents. Okay, so what we don't want to see happen now is that people start focusing on this list only, and we start to see a drop off in open disclosure for, as Bernie said, some other very, very catastrophic category 1 incidents where people are left with a major disability following an incident, or really where a patient has suffered any harm. Open disclosure should occur. It doesn't matter about the level of harm that it is. So I think that while it's nicely aligned, it builds on our policy and doesn't replace our policy, and we continue with the implementation. And as I think Tony referred to it earlier, it's building on that culture of openness, transparency and compassion that all patients and families should receive when they've been involved in a patient safety incident. Again, the additional requirements around this Act is the notification to the regulator within 7 days, as Lorraine said, and then there's that official appointment of the designated person. So that appointment is done in writing, and it's kept on record by the service provider. And also there's the documentation requirements as well, that the written statement or the written record of the open disclosure meeting has to be given at the meeting or within 5 days. And that's not 5 working days, it's 5 days of the open disclosure meeting. And really, I think Paula referred to it earlier as well, we really want to see better documentation of open disclosure. So this Act is really going to kind of help drive really good documentation practices when open disclosure is happening at every stage of that process, really. So we see this as building and aligning more with a few additional requirements to current HSE policy. And that's the message we really want everyone to bring home today. And to, as John was saying, about calming the situation, that this is our practice normally. And there's just these number of little extra things we have to do to meet the Act, really.
Okay, thank you for that, Angela. Just maybe before we move on, just might come back just to one other question there in terms of, obviously we talked a lot about training today and training and development for things like the designated officers and that. Could you maybe just give us a sense of the timeframes, just to sum up those timeframes for people so that they have a sense of when they can do training on the Act?
Okay, so for currently, people who are attending face-to-face skills training in open disclosure, you just contact your open disclosure lead, and there is some training high-level overview of the Act being provided in that training. We're currently developing a full e-learning program on the Act in its entirety. So we hope to have that e-learning developed by the end of June is our current deadline for it. So, and we have started that work with HSE Land. So again, we all see this. We hope to have these programs up and running by Q3, end of Q2, beginning of Q3. The designated person, face-to-face training and e-learning training, again, we're aiming for the end of June, so maybe beginning of July. So we definitely will have these programs ready in Q3 this year. So just for the system to take, I suppose, like reassurance that we're doing an awful lot behind the scenes here to help people with the implementation of the Act and the development of documentation templates that are required in the Act, etc. So I think just be reassured that there is a lot coming down your way to support you with this.
Okay, thanks for that, Angela. And just maybe one for you, Lorraine, just in terms of the HSE preparing for the commencement of the legislation. I know we talked about within the services, within the acutes and within the community services, but is there anything additional from a broader national context that you wanted to touch on before we finish up?
Well, we have the implementation group, which is very strongly represented, I think, from across the HSE and colleagues outside of the HSE as well. And Bernie sits on that as well. So we're very grateful of the support. So we have a number of those actions, as I mentioned earlier, specifically looking at the open disclosure processes, operational kind of readiness, what that means, the NIM system kind of specific around the screening. I know colleagues from screening aren't on today, but they're doing quite a lot of work to meet the legal requirements set out in the Act as well. And then, yeah, just I suppose it's a constant engagement, getting feedback from the ground, and not to forget the kind of staff support piece as well. So with the kind of two angles of making sure that staff feel supported, that they feel ready for the implementation of that, but also that we build on supports for them if they're being involved in an incident and the kind of trauma that comes along with that, to make sure that we can deliver on the Act and maintain the compassionate approach to it, partnership with our patients and those affected.
Thanks, Lorraine. Thanks for that. It's helpful to have that broad oversight, I think, because I'm sure people are wondering, how do these decisions get made? When we're looking at commencement, how do those things happen? So it's helpful to have a sense of that. There is a question there about how does Section 39 submit notification, as currently we're not reporting on NIMS. It might be one for Helen or for Angela.
Or Lorraine can do it. Yeah.
Lorraine, yeah.
Speak to it.
Yes. So there will definitely be clear guidance. So the State Claims Agency obviously have the contract of the system and kind of lead out on the technical changes. The system is written into the legislation. So whilst private providers don't have login details to the system, they are building a specific portal. So private providers, Section 39's, GPs, community pharmacies, and that will be able to report a notifiable incident via this portal. They are very active in that development phase at the moment, so there will absolutely be clear guidance from the regulator, because obviously the regulator, their scope is wider than the public healthcare system in terms of how to report via that portal. And as Angela said earlier, the important piece for us within the HSE and colleagues who use the system is they do it via the incident management module that they have access to.
Okay, thanks for that, Lorraine. That's a really helpful clarification, and good to know that there's a lot of collaboration in the development of it as well. I think that's good to know. There's also a question just from Dr. Nicola Marr in terms of the designated person, and I think that Paula's description, I'm sure people will be looking for a link to it, but there was, I suppose, a question about whether or not there's a document that might give a skill set in terms of what's important or essential for this role. And maybe Angela or Paul, you might like to touch on that one.
I think Paula can speak probably the background to the people better, because it does vary, and maybe Paul will cover that. In relation to the role, there are 2 documents, and maybe the girls might put the links into the chat for people. So we have a role of the designated person document that's written out, and it's on our website, hse.ie/open disclosure, under resources for staff and organisations. And there's also a checklist that we've developed for the role of the designated person as well. So, and that's an open disclosure. So we're working to extend that role at the minute to incorporate the role within incident management and open disclosure, because they would be the same person. Person supporting the incident review would be the same person generally who would be supporting them through the open disclosure process. And I'd maybe go over to you, Paula, maybe around the background for the persons that, because you're working with quite a few.
Yeah, and thanks, Angela. Background, I have a mix. Not all clinical backgrounds. I have nursing background. I've had a speech and language therapist. I have mental health backgrounds. Just trying to think of all the staff I have. I've somebody coming from a social care background. So it's the skill set rather than the background. It's somebody who's got really good communication skills, and in fairness, you can train people up, but I have found in my experience of having designated persons in the role for the last couple of years that it's not everyone is for the role. You really need to carefully select the people to do this role, because it's a vitally critical role for the people who are affected by these serious incidents, and you do need to give it due consideration and thought. It's a vitally important role, and you need to get it right. And even with that, and you think we have it right, we still make mistakes. And I think the piece that's in the Act that I love is that we learn, is that we need to learn from each one that we do, because I have found from every open disclosure meeting that I have done, you learn.
You learn something else.
So it's really, really important, I think, but it is the important piece. They can come from any background. Is just making sure that they have the right skill set, or they're the right people for the role.
To do that. No, thanks for that, Paula. And I'm conscious, just you touched on having the right skill set, but there's also that piece about supporting staff and the work, and I know that you do a lot of support of staff in that space, but equally there's a lot of resources and supports there. And I don't know, Angela or Lorraine, would you like to just touch on the supports available for staff, and then we might just go back to John then just for a final sum up, because we're coming close to the time.
I'm happy to come in here, Lorraine, and you maybe want to add to it. Just wanted to go back to what Jack was saying earlier in relation to the supports that doctors need, and really it's really important that they get that peer support on the ground. Like we've got lots of wonderful service through employee assistance program, through occupational health, but really when something goes wrong, probably John can allude to this as well in his role, is that when something goes wrong, you really rely on your peers to support you, so that's the team around you. It's not just the medical team, it's the nursing team, quality, patient safety department. So when something goes wrong, and Helen and Paula are very used to this, that when something goes wrong, the quality and patient safety team are there. They will help and guide and direct doctors, particularly in relation to the management of these incidents, keeping them right. So that, and usually you don't have to go to them, they'll come to you, isn't that right, ladies? So when an incident of this category has occurred, so I really want to talk about the really important role of the QPS department, but also that support on the ground. And we have our Assist Me booklet that we developed, and this little Assist Me document we developed, and it's been approved through our employee assistance program as well. It really is a very practical document that you can use to actually, support yourself, to know what to recognise a normal reaction to an abnormal situation, to know how to help yourself, to know how to support a colleague, and to know when to actually avail, what symptoms you should be worried about that would lead you to avail of, the care of your GP or other service then, or counselling, etc. So they're all there, as is then our support through our training programs. We have numerous resources on our website, really helpful resource, and I would really point out our quick reference guide and toolkit for anybody who's engaging in open disclosure discussions. Really does keep you right. There's documentation templates there. There are sample language. There are just so many documents. Documents on how to apologise, the language to use, language to avoid, etc. So do visit our website and utilise the resources there for you.
Perfect. Thanks very much to everybody, and thanks for the panel for participating in the chat. I know there's a few more questions have come in there, and there will be, you know, a series of answers up online on the website. As we see sort of questions coming in, they'll be forwarded on to Angela and to Lorraine, so that the team will be able to respond, and that they'll be available. The information will be available. So over to you, John. Thanks, everybody.
Thanks, Juanita. And just to pick up on Angela's point there, I absolutely agree. You know, I think consultants have a huge role in the successful, you know, the successful commencement of the Act. And I think, you know, we welcome, you know, that the interest the NCHEs are showing, but I think, you know, consultants are very often going to be the principal healthcare providers, and will very much work with the NCHDs, I think, and to support them. But I think the consultants certainly will be very much involved in this, and I think it's important that consultants make themselves aware of the provisions of the Act as well. I'm going to kind of start to wrap things up. I know we started a few minutes late, so we might just take a few minutes. I'd like to, again, just thank, like Juanita did there, all the panelists. I think I might just go very briefly back to Bernie and to Tony, who've been listening in, I think, and to thank them again for starting and framing the discussion at the beginning. And I think, Bernie, it was clear that you welcome the Act in terms of making sure that it now is extended beyond just the HSE, and in particular, you know, roles like the designated person that would have been so important for you and your family. If I could just ask you for a brief kind of thought, having listened to the conversations over the last little while, what you make of all the preparation now for the commencement of the Act.
I think the most important thing is always keep communication channels open. Like, intervene early, keep the channels open.
Yeah.
The court system is a robust system, but it's a cruel system. And patients, their families, and healthcare staff, it's not a place for any of them, because we're all innocent people in this, and the law courts just, they don't take account of the harm and the frustrations that people bring with them and the fear. So I think keep communications open. The designated person would be the most important person in my life if I was in a notifiable incident situation again. So always communication, most important.
Yeah,
Thanks.
super. And I think, yeah, that reminder, you know, because it's an act and it's the law, we still, none of us want to be in court. Nobody wants to be in court, and we can do this much better, I think, through communication, like you said, and thank you for that. And Tony, just to you again, I was impressed by what you said earlier about this is a platform for us to go beyond just responding to incidents and to learn how to do safety better. Just your thoughts on the conversation.
Yeah, actually, I was really, reassured might be the wrong word, but in a sense, reassured by the amount of training that's going to be available, that is available for people that find themselves in these circumstances, for our staff. It's not, I mean, it's extremely difficult, and for lots of people, it is something that happens once, or maybe, you know, if they're unfortunate, might happen a couple of times in their whole career. So having that training and having that, you know, I suppose that system and the resources that go with that, I think, is really important. It helps them to do a good job, gives them a bit of confidence in what they're trying to do as well. You know, so I was really impressed with that. I think that'll make a big difference. Yeah, and it's important to remember, you know, that, you know, our staff, you know, like all of these interactions are people with people. You know, so helping them to do that better, I think, is important. Yeah.
Yeah, thank you both very much, and again, thank you to all our panel. Yeah, again, I'll take away lots from this conversation, and I think the expertise of the panelists here, who again are all working in the system, you know, and the tremendous knowledge that's there, the tremendous knowledge that our colleagues in the open disclosure team and incident management team have. Lorraine and Angela, thank you for sharing that with us today, and thank you for all the people in the background who have supported this. There's a lot of work to do, but I can see, you know, there's a lot going on and there's a lot available. We might just bring the slides up there just to maybe point people to some of the resources that are available.
John, just to thank yourself and Juanita as well for facilitating the session today. No easy task to keep us all time and everything. So just say thank you very much for all your work and preparation for today, and for the excellent facilitation today. We really greatly appreciate it.
Thanks, Angela. A couple of e-learning modules. These are available on HSE Land, and you can see the links there. Again, the slides will be available. There's one for everybody, and then one for those who are applying principles to practice. So for people at a more advanced level. So please do check out those. They are mandatory, so I think it will be important, you know, that people get that training and access it through HSE Land. You're going to receive an evaluation with the short survey after today's webinar, and again, we really appreciate feedback you give, because we do listen and try and learn from that, and it will inform future webinars. So please do fill in the evaluation. The next webinar, again on the Patient Safety Act, will be on the 17th of April. I think at this occasion, I'm going to go into a little bit more detail about the notifiable incidents, in particular in relation to surgery, obstetrics, neonates. So I think, you know, there'll be probably a bit more communication beforehand about that, with detail for those particular areas, and I think that will be of particular interest to people working in those fields. Just a plug for QPS Talk Time, just to let people know that's a webinar that happens every second week, and our next webinar is on the 9th of April, 1 to 2 p.m. It's always on a Tuesday, every second Tuesday, and this one is on person-centered lean with Dr. Sean Paul Teeling from the Lean Academy at UCD in the Matter. That'll be something that I'd encourage people to check out, and just to let people know about our Walk and Talk Improvement podcast series there, and also the QPS Patient Safety Matters. If you want to check out the publication, the QR link will take you there. National Consent Policy, people may want to check that out. And you'll find more information about the Patient Safety Act on our website. So thank you very much, everybody, for joining us today, and we look forward to seeing you on the 17th of April. Goodbye.
Thanks, everybody.
Thanks, John. Thank you.
Kelly, we might just move into private session, or Chris, if that's okay.